Welcome to Bookfulness, your comprehensive guide through clinically oriented anatomy. This deep dive is episode 29, and we're continuing our journey down the lower limb. Last time, we really got into the powerhouses, the gluteal region, and the posterior thigh.
That's right, big muscles, big movements. Today, though, we shift gears quite a bit. We're moving distally, behind the knee, into a region that's less about bulk and maybe more about intricate packaging.
The popliteal fossa.
Exactly, that complex space behind the knee. And then we'll look at the leg itself, how it's organized into these really distinct fascial compartments. Our focus today is understanding how this anatomy, especially these tight spaces, dictates function, particularly during walking.
Okay, let's start with the popliteal fossa. It always gets described as diamond-shaped. So for anyone trying to picture this, what actually forms the borders of this, well, critical crossroads behind the knee?
Yeah, crossroads is a good word for it. It's the main highway for nerves and vessels between the thigh and the leg. Think of the muscles defining it. Superiorly and out to the side, you've got the biceps femoris.
Oh.
Then superiorly and more towards the midline, that's the semimembranosus and semitendinosus.
The hamstrings we met last
The
time.
very same. Then, forming the bottom point of the diamond, you have the two heads of the gastrocnemius muscle, the big calf muscle.
Got it. So muscles form the sides. What about the roof and floor?
Well, the roof is just skin, and then this really dense layer of fascia, the popliteal fascia. The floor is deeper. You're looking at the back surface of the femur bone, the posterior part of the knee joint capsule itself, and actually the popliteus muscle, which lies really deep in there.
So it's fairly well-defined muscular box. And packed inside are the main supply lines and nerves for everything below the knee. What's the arrangement? You always hear there's a specific order from superficial to deep.
There is, and it's clinically really important to remember. If you were dissecting from the skin inwards, the very first major stressor you'd encounter is the tibial nerve.
Okay, nerve first.
Then, just deep to that, you find the popliteal vein.
Vein second.
And then, deepest of all, lying right up against that floor, the bone and joint capsule is the popliteal artery.
Nerve, vein, artery. NVA, superficial to deep.
Okay.
So the artery is the deepest. You'd think being deep would protect it, but you often hear it's particularly vulnerable here. Why is that? Is it being pinned against the bone?
That's exactly it. It's that very close, sort of unforgiving relationship with the hard structures of the floor, the femur, and the joint capsule. When you have severe trauma, like a posterior knee dislocation, which is a violent injury,
Right.
the forces involved can actually shear the artery against those hard surfaces. Or if there's a distal femur fracture, bone fragments can directly lacerate it.
And the consequences sound pretty dire. Double trouble, really.
Absolutely. First, you've got immediate, potentially massive hemorrhage because it's a large, high-pressure artery. But just as critically, you instantly cut off the blood supply to the entire leg and foot below the knee. And the texts are really clear on this. If that rupture isn't recognized and surgically repaired, like fast, you can get irreversible tissue death, ischemia, within just a few hours.
Wow.
It often means amputation is unavoidable. It's a true vascular emergency. Sometimes the vascular repair has to happen even before the orthopedic surgeons can fix the bones or the joint.
It's tense. Okay, sticking with vascular issues, but shifting from trauma. What about problems within the artery itself, like a popliteal aneurysm? An aneurysm is basically a bulge or dilation, right? That was cause issues in such a tight space.
It definitely does. And it's actually not that uncommon. It's one of the more frequent sites for peripheral aneurysms after the aorta and the femoral artery. Patients might notice swelling or a dull ache behind the knee.
But how do you know it's an aneurysm and not, say, just a cyst or something else?
Good question. There are specific vascular signs you look for. You might be able to feel a distinct pulsation when you gently palpate the area that's called a thrill. And if you listen with a stethoscope, you might hear abnormal, turbulent blood flow sounds, whooshing noises called bruits. These are pretty strong clues.
And these signs are critical because of what's lying right on top of the artery.
Exactly. Remember our order: nerve, vein, artery. The tibial nerve is sitting just superficial to the artery.
So if the artery starts ballooning out?
It directly pushes on or stretches the tibial nerve. This mechanical irritation is what often leads to referred pain.
Referred pain meaning the pain isn't felt just where the problem is.
Right. The aneurysm itself might just cause local aching, but the nerve irritation causes pain that radiates down the leg, typically following the nerve's distribution. So patients might complain of pain, numbness, or tingling in the calf, maybe around the medial ankle, or even into the sole of the foot. That nerve stretching can be an early warning sign.
So that popliteal artery, it's really in a precarious spot. If it does get blocked or cut, is the leg just done for? Or is there any kind of backup system?
Thankfully, the body usually builds in some redundancy. Around the knee, there's a network of smaller arteries called the genicular anastomosis. Think of it like a series of small bypass roads around the main highway.
So smaller arteries connecting above and below the knee joint.
Precisely. There are several named genicular branches: superior medial, superior lateral, inferior lateral, and a middle one that branch off the popliteal artery itself, but also connect with descending branches coming down from the femoral artery in the thigh.
So these connections form a loop around the knee.
Yes, a collateral network. The idea is that if the main popliteal artery gets slowly blocked, maybe by plaque buildup in peripheral arterial disease,
Wow.
these collateral vessels can gradually enlarge over time and provide an alternate route for blood to reach the lower leg.
But does it work well in sudden trauma, like we discussed?
That's the catch. In slow chronic occlusion, it can sometimes compensate quite well. But if the popliteal artery is suddenly severed, like in a bad fracture or dislocation, this collateral network usually just can't supply enough blood quickly enough to prevent ischemia.
So it's a backup, but maybe not a foolproof one for emergencies.
Exactly. It highlights a principle we see elsewhere too. These continuous chains of interconnected arteries running down the limb provide some safety, but the main pipeline is still critical. Hashtag tag tag 2. The leg compartments and the anterior group.
Okay, let's move down from the fossa into the leg proper. The organization here seems really different. You mentioned compartments, 3 of them: anterior, lateral, and posterior. What's the big deal about them being compartments?
Right.
Why is that structure so important?
It's all about managing forces and functions in a relatively small space. The leg below the knee has the tibia and fibula bones connected by a really tough sheet called the interosseous membrane. Then you have these incredibly strong sheets of connective tissue, fascia, that run from the fibula out to the deep fascia surrounding the whole leg. These fascial septa basically divide the leg musculature into 3 completely separate, non-communicating boxes or compartments.
Closed boxes, essentially.
Yeah.
They can't really expand outwards.
Not really. They're bounded by bone, the interosseous membrane, and these tough fascial walls. They're pretty much unyielding.
Okay, I think I see where this is going. If something causes swelling inside one of these closed boxes,
The pressure inside has nowhere to go but up, dramatically. And that's the basis of compartment syndrome, whether it's muscle swelling from overexertion, bleeding from trauma, or inflammation from infection. The rising pressure starts to crush everything inside the compartment.
crushing what exactly?
The muscles themselves, but also, critically, the nerves and blood vessels running through that compartment. If the pressure gets high enough to cut off blood flow, the muscles and nerves can start to die pretty quickly. Irreversible damage.
That sounds incredibly serious. Which compartment is most commonly affected?
The anterior compartment is generally considered the most susceptible.
Okay, let's focus there then. The anterior or dorsiflexor compartment. Where exactly is it and what's its main job?
It's located right in front of that interosseous membrane, nestled between the shaft of the tibia medially and the fibula laterally. Its name tells you its function. The muscles here are primarily responsible for dorsiflexion, pulling your foot and toes upwards towards your shin, and also for extending your toes.
And who are the main muscle players in this compartment?
There are 3 main ones you need to know. The largest and most medial is the tibialis anterior, or TA. Then you have the extensor digitorum longus, EDL, which sends tendons out to extend the 4 smaller toes. And finally, the extensor hallucis longus, EHL, which is dedicated to extending the big toe, the hallux.
Tibialis anterior, extensor digitorum longus, extensor hallucis longus. Got it. These muscles sound like they work hard, especially their tendons crossing the ankle.
They do, and the body has a system to manage that. As these tendons run down over the front of the ankle, they're held firmly in place by strong bands of fascia called the extensor retinacula. There's a superior one and an inferior one, shaped kind of like a Y.
What do these retinacula do? Like ligaments?
Sort of, but they act more like straps or pulleys. They prevent the tendons from bowstringing, popping up away from the bones when the muscles contract hard. This keeps the line of pull efficient and close to the joint, allowing for smooth movement.
Makes sense. Now, back to compartment syndrome. Why is this anterior compartment the one that gets into trouble most often? You said it's tightly confined.
Yeah, it's a combination of factors. It's already a relatively small space, tightly bound by the tibia, fibula, interosseous membrane, and that strong, deep fascia on the front. Plus, the muscles in here, especially tibialis anterior, undergo really forceful contractions, both shortening and lengthening, particularly during activities like running or hiking, especially if you're not conditioned.
So overuse can cause swelling.
Definitely. Or direct trauma, like getting kicked in the shin, can cause bleeding into the compartment. Even a small amount of extra fluid in this tight space can rapidly jack up the pressure to dangerous levels. Injury to the anterior tibial artery, which runs right through here, is a classic cause. Hashtag tag 3, anterior compartment neurovasculature and function in gait.
Okay, let's dig into the details of this anterior compartment. What nerve and artery supply these muscles?
The neurovascular supply is quite specific. The nerve is the deep fibular nerve, sometimes called the deep peroneal nerve, and the artery is the anterior tibial artery. They run down together within the compartment.
Deep fibular nerve and anterior tibial artery. Got it. And you mentioned the muscles. Tibialis anterior, TA, extensor digitorum longus, EDL, extensor hallucis longus, EHL. Where do they actually attach distally? That determines what they pull on.
Right. The TA, the big dorsiflexor, inserts on the medial side of the foot onto the medial cuneiform bone and the base of the first metatarsal. This position allows it to both dorsiflex and help invert the foot slightly. The EDL tendons spread out and attach to the middle and distal phalanges, those little bones, of the 4 lateral toes. So it extends those toes.
Makes sense.
And the EHL, as its name suggests, goes specifically to the distal phalanx, the very tip bone of the great toe, extending it.
Understanding those attachments really helps visualize how they work during walking, during the gait cycle. These muscles seem essential for a smooth stride.
Absolutely essential. They have 2 critical jobs during different phases of walking. We usually think of gait as having a swing phase when your foot is off the ground,
Yeah.
and a stance phase when your foot is on the ground bearing weight.
So what do the anterior compartment muscles do during the swing phase?
During swing, as your leg is moving forward, these muscles contract. Concentrically, they shorten to pull your foot and toes up into dorsiflexion.
Why is that important?
It's crucial for toe clearance. Lifting the front of the foot ensures you don't stub your toes or catch your foot on the ground as you swing it through. If you lose this function, that's when you see foot drop, where the foot hangs down and people have to lift their knee really high to compensate.
Okay, so that's swing phase, lifting the foot. What about stance phase, when the foot hits the ground?
This is their second key role, and it happens right at the beginning of the stance phase, called the loading response, just after your heel hits the ground.
What happens then?
Well, gravity and momentum want to make your foot slap down onto the ground quickly. The dorsiflexors, mainly the TA, prevent this by contracting eccentrically.
Eccentrically, meaning?
Meaning the muscle is active and generating tension, but it's actually lengthening, not shortening. It acts like a brake, controlling the descent of the forefoot. It slowly lowers the foot to the ground in a controlled manner.
So it's like shock absorption.
Exactly. It smooths out the impact of landing and prevents that foot slap. It's a controlled deceleration.
I remember reading that this eccentric contraction, this braking action, is actually quite demanding for the muscle. Uses a lot of energy.
That's a really interesting point. Eccentric contractions, where the muscle fights against being stretched, generate very high forces within the muscle fibers. While they're powerful for control, they are metabolically quite costly. It puts more strain on the muscle tissue compared to concentric contractions and can contribute significantly to muscle soreness after unaccustomed exercise, like that shin pain people get after a long hike. Hashtag 4, the small lateral compartment.
Okay, moving sideways from the anterior compartment, we get to the smallest one, the lateral compartment, also known as the evertor compartment. What muscles live here and what's their job?
This is a much smaller compartment, basically located on the lateral side of the fibula bone. It contains just 2 muscles, the fibularis longus, also called peroneus longus, and the fibularis brevis, peroneus brevis.
And their main action is everversion, turning the sole of the foot outwards.
That's their primary role, yes, everversion. The fibularis brevis inserts onto the base of the 5th metatarsal on the outside of the foot, while the longus tendon takes a fascinating path, crossing underneath the foot to insert on the medial side near the tibialis anterior insertion.
Wow, all the way across.
Yeah, it helps support the transverse arch of the foot as well. Together, they avert the foot and also contribute a bit to plantarflexion, pointing the foot down. They're really important for stability, especially when you're walking on uneven surfaces, helping to prevent your ankle from rolling inwards.
And the nerve supply for just these 2 muscles.
That comes from the superficial fibular nerve, or superficial peroneal nerve. It branches off the common fibular nerve higher up.
And is this nerve vulnerable too? Everything seems vulnerable down here.
It is, unfortunately. After supplying the muscles, the superficial fibular nerve continues down to provide sensation to the skin on the lower lateral leg and most of the top, the dorsum, of the foot. To do this, it has to pierce through the deep fascia, usually in the lower third of the leg, to become superficial.
And that piercing point is a weak spot.
It can be. The nerve is also relatively exposed as it runs down the side of the leg. This makes it susceptible to injury, particularly from recurrent stretching.
Like what happens in an ankle sprain.
Exactly. The most common type of ankle sprain is an inversion injury, where the foot rolls inwards. This can violently stretch the structures on the outside of the ankle, including the superficial fibular nerve. If this happens repeatedly, like in chronic ankle instability, it can lead to nerve entrapment or irritation, often where it pierces the fascia.
And what would the symptoms be? Similar to other nerve issues.
Pretty classic nerve symptoms.
Yeah.
Pain, numbness, or tingling paresthesia along that lateral leg and the top of the foot. A key feature is that the symptoms often get worse with activity, like walking or running, as the nerve gets compressed or irritated by movement and might feel better with rest.
Okay, one last thing about this lateral compartment. You mentioned earlier that infections usually stay within a compartment or spread downwards, but this one's different.
Yes, this is a peculiar exception mentioned in the texts. While most compartments contain infection, a pus-forming or purulent infection in the lateral compartment has been known to sometimes track proximally upwards along the course of the fibular nerve.
Up towards the knee, into the popliteal fossa.
Potentially, yes. It seems the pathway along the nerve can act like a conduit, allowing infection to bypass the usual fascial barriers and spread upwards, which is obviously quite dangerous given the critical structures in the popliteal fossa we discussed earlier. It's a rare but important clinical point. Hashtag 5. Posterior compartment, the superficial group.
All right, let's move to the back. The largest compartment by far. The posterior compartment, the plantarflexors. This one's so big it's divided into superficial and deep groups. Let's start with the superficial layer, the muscles you see as the bulge at the calf.
Right. This is the superficial group, dominated by the triceps surae. That literally means the three-headed muscle of the calf.
3 heads. Which muscles make those up?
It refers to the 2 heads, a medial and a lateral head of the gastrocnemius muscle, which is the most superficial one you see,
Okay.
and the underlying broader soleus muscle. Some people also include the small, often skinny plantaris muscle in this group, though its muscle belly is small and it has a very long, thin tendon.
Gastrocnemius, soleus, and plantaris. And they all come together at the bottom.
Yes. Their defining feature is that they all merge distally to form the massive, incredibly strong calcaneal tendon, which most people know as the Achilles tendon. This tendon inserts onto the back of the calcaneus, the heel bone.
So functionally, gastrocnemius and soleus seem similar. They both plantarflex the foot, point the toes down. Is there difference in how they work?
There's a very important difference based on their origins. The gastrocnemius actually originates from the femur, above the knee joint. This means it crosses 2 joints, the knee and the ankle. Because of this, it's a powerful plantar flexor, but it works best when the knee is straight, extended. It's also got more fast twitch muscle fibers, making it key for explosive movements like jumping and sprinting the initial push-off.
And the soleus.
The soleus lies underneath the gastrocnemius, and it originates from the tibia and fibula below the knee joint, so it only crosses the ankle.
So its action isn't affected by knee position.
Exactly, and it's primarily composed of slow-twitch, fatigue-resistant fibers. This makes the soleus the real workhorse for endurance activities, standing, walking, maintaining posture. It provides that continuous plantar flexion force needed to propel you forward during the stance phase of gait.
That makes sense. Now, the Achilles tendon itself, it's famously strong, but also famously prone to rupture. Clinically, how do we assess its integrity? The ankle jerk reflex.
Yes, the calcaneal tendon reflex, or ankle jerk, is a standard neurological test. You have the patient relax their foot slightly, then you tap the Achilles tendon briskly with a reflex hammer just above the heel.
And the normal response.
Is a quick, involuntary plantar flexion of the foot jerks downwards.
What does that reflex tell us? Which nerve roots?
It primarily tests the integrity of the S1 and S2 spinal nerve roots and the associated segment of the spinal cord. If the reflex is absent or significantly diminished, it can indicate a problem like a herniated disc compressing the S1 nerve root or damage to the tibial nerve, which carries both the sensory input and motor output for the reflex.
And what if the problem isn't the nerve, but the muscles or the tendon itself? Say someone ruptures their Achilles tendon, a common sports injury. What happens to their ability to walk?
It's devastating for propulsion. Losing the function of the gastrocnemius and soleus means you lose that powerful push-off from the ground. Walking becomes very difficult and inefficient.
How do people compensate? They can still walk, usually.
They can, but it's a very altered gait. Without the calf muscles providing the main push, the body weight just passively forces the ankle into dorsiflexion during the late stance phase. To move forward, patients have to rely heavily on their gluteus maximus and hamstrings to extend the hip more forcefully. They also often externally rotate their whole leg and sort of throw the foot forward to get clearance and momentum. It's a much less efficient, more tiring way to walk.
One last quick thing about this superficial group. Sometimes you see a little extra bone on x-rays near the knee, the fibella.
Ah, yes, the fibella. It means little bean in Latin. It's a small sesamoid bone, a bone embedded within a tendon that's sometimes present in the tendon of the lateral head of the gastrocnemius, right where it passes over the lateral condyle of the femur.
Is it common? Does it cause problems?
It's a normal anatomical variant found in maybe 10–30% of people, depends on the study. Usually it's completely asymptomatic. It just shows up on an x-ray, and it's important for clinicians to recognize it as normal and not mistake it for, say, a fracture fragment or a loose body inside the joint. Hashtag tag 6, posterior compartment deep group and clinical summary.
Okay. Peeling back the gastrocnemius and soleus, we get to the deep group of the posterior compartment. Which muscles are hidden back there?
There are 4 main muscles in this deep layer. Running obliquely behind the knee is the popliteus, which helps unlock the knee from full extension. Then, running down the leg, you have 3 muscles whose tendons pass behind the medial malleolus, the inner ankle bone.
The Tom, Dick, and Harry muscles.
That's the mnemonic. Tibialis posterior, Tom, flexor digitorum longus, Dick, which flexes the smaller toes, and flexor hallucis longus, Harry, which flexes the great toe.
So tibialis posterior, flexor digitorum longus, flexor hallucis longus, what's their main combined action besides helping with plantar flexion?
They are also key inverters of the foot, working with the tibialis anterior. But maybe even more importantly, the tibialis posterior in particular is crucial for supporting the medial longitudinal arch of the foot. And the FHL provides the final powerful push-off from the big toe during walking and running.
And the nerve and artery supply for this deep group? Still the tibial nerve.
Yes, the tibial nerve supplies all the muscles in the posterior compartment, both superficial and deep. The main blood supply comes from the posterior tibial artery, which runs down with the tibial nerve, and also the fibular artery or peroneal artery, which typically branches off the posterior tibial artery higher up and supplies structures more laterally.
Okay, let's connect that tibial nerve pathway to a clinical issue. As it leaves the leg and goes into the foot, it can get trapped. Tarsal tunnel syndrome.
That's right. After the tibial nerve passes down the leg, it curves around behind the medial malleolus. Here, it passes through a channel formed by the bone and a thick band of fascia called the flexor retinaculum. This channel is the tarsal tunnel.
Similar concept to the carpal tunnel in the wrist.
Exactly the same idea. The tunnel is a tight space, and the flexor retinaculum forms an unyielding roof. If there is any swelling inside the tunnel, perhaps from inflammation, a cyst, or even thickened tendons, it can compress the tibial nerve.
And the symptoms would be nerve-related in the foot.
Yes. Compression here typically causes pain, burning, tingling, or numbness primarily on the sole of the foot. Because the nerve usually divides into its main plantar branches within or just distal to the tunnel, the symptoms often affect the heel, arch, and plantar surfaces of the toes. In long-standing cases, you might even see weakness or wasting of the small intrinsic muscles of the foot that the nerve supplies.
Moving to the artery down there, the posterior tibial artery, palpating his pulse sounds like a really important check.
It's fundamental, especially when assessing for peripheral arterial disease, or PAD. You feel for the posterior tibial pulse in the groove just behind and slightly below the medial malleolus, about halfway towards the heel.
And what does it mean if you can't feel it?
While a small percentage of younger, healthy individuals might have a non-palpable pulse as a normal variation, its absence, particularly in someone over 60 or with risk factors like smoking or diabetes, is a very strong indicator of significant blockage or narrowing occlusive disease in the arteries supplying the leg.
And that blockage often causes a specific type of leg pain, right? Claudication.
Yes, intermittent claudication. This is the classic symptom. It's described as cramping, aching, or tiredness in the muscles, usually the calf that comes on consistently after walking a certain distance, and crucially, is relieved predictably by resting for a few minutes. It signals that the muscles aren't getting enough oxygen during exertion because of the poor blood flow.
Okay, before we wrap up with the big clinical takeaways, let's quickly touch on surface anatomy. If someone wants to feel these structures on their own leg, what are the key landmarks? The shin bone.
Definitely start with the tibia. You can feel the anterior border of the tibia, the shin, very easily. It's that sharp edge running all the way down from just below the kneecap, the tibial tuberosity, to the inner ankle bone, the medial malleolus. It's subcutaneous, meaning there's basically just skin over it.
Which is why banging your shin hurts so much.
Precisely. The whole medial surface of the tibia, the flat part on the inside, is also just under the skin.
What about the ankle bumps, the malleoli?
You can easily feel both. The medial malleolus is the bump on the inside, the distal end of the tibia. The lateral malleolus is the bump on the outside, the distal end of the fibula. Notice that the lateral malleolus usually feels more prominent, extends a bit further down, and sits slightly more posterior, further back than the medial one.
That difference is important for ankle stability, I imagine. Can you feel any of the tendons we talked about?
Yes, especially the anterior ones. If you pull your foot up and slightly inwards against resistance, you'll see and feel the thick tendon of tibialis anterior popping up right next to your shin bone.
Okay, yeah, I can feel that.
Now, keep your foot like that, but specifically lift just your big toe up as high as you can, just lateral to the TA tendon. You should be able to feel or even see the tendon of the extensor hallucis longus becoming prominent.
Ah, yes. Cool. Okay, let's bring it all together clinically. 3 big issues often come up with the leg. First, let's re-emphasize compartment syndrome.
Absolutely critical. Remember those tight, unyielding fascial boxes? Any swelling from injury, bleeding, or even severe muscle exertion can raise the pressure inside, cutting off blood flow and potentially killing muscle and nerve tissue. The anterior compartment is the classic site, but it can happen in any of them. Early diagnosis and treatment, often surgically opening the fasciotomy, are vital to prevent permanent damage.
Second big issue, foot drop. We mentioned it earlier. What's the direct cause?
Foot drop. The inability to lift the front of the foot is almost always caused by damage or compression of the common fibular nerve, or its branch, the deep fibular nerve. Since the deep fibular nerve is the only nerve supplying the anterior dorsiflexor compartment muscles, injuring it leads to paralysis of those muscles. No dorsiflexion means the foot hangs down during swing phase.
Leading to that high stepping gait to avoid tripping.
Exactly. The steppage gait.
And finally, the general term shin splints. The book mentions stress fractures in this context. What's the specific issue there?
Shin splints is a bit of a catch-all term for pain along the shin, but one specific cause, especially relevant here, is a tibial stress fracture, sometimes called a Murch fracture. These often occur in the lower third of the tibia.
Why there specifically?
This area seems particularly vulnerable, especially in people who suddenly increase their activity level, like new runners or military recruits. Part of the reason might be biomechanical stress concentration, but importantly, the text points out that this distal third of the tibia naturally has a poorer blood supply compared to the rest of the bone,
Making it harder to repair microdamage from repetitive stress.
That seems to be the thinking, yes. Compromised healing capacity under load leads to the fracture.
Okay, so if you had to boil down the entire functional design of the leg compartments into one key message, what's the bottom line?
The bottom line is this elegant division of labor for efficient walking and running. The anterior compartment acts primarily as the controller during the swing phase, lifting the foot, and the brake during initial stance, controlling heel strike via eccentric contraction. In stark contrast, the much larger and more powerful posterior compartment acts as the engine, providing the strong plantar flexion force needed for the propulsive push-off phase. It's this interplay between control and power across the compartments that allows for smooth, efficient human locomotion. Hashtag taxi Ch.7.
So we've journeyed through the surprisingly complex popliteal fossa, highlighting that critical neurovascular bundle and particularly the vulnerability of the popliteal artery deep within it.
And then we dissected the leg itself, clarifying the distinct roles of those 3 tightly bound fascial compartments, the anterior dorsiflexors controlling foot placement, the small lateral evertors providing stability, and the powerful posterior plantarflexors driving us forward. We also covered the significant clinical implications, from compartment syndromes and nerve entrapments to how specific injuries affect gait.
It really emphasizes how structure dictates function, especially under the high demands of movement. Next time on Bookfulness, we're moving further distal still into the intricate structure of the foot and ankle itself. We'll be looking at the numerous bones and joints, focusing particularly on how the subtalar and transverse tarsal joints work together to allow the foot to adapt to different surfaces. Thank you for joining us for this deep dive into clinically oriented anatomy. Thanks for listening to Bookfulness.